Hello, everyone. Welcome to another episode of our videocast. Today, our topic is the stroke. And we have one of the top experts, Professor Dr. Luft from Switzerland. I will quickly introduce him. He is by formation a neurologist. I read that he studied and worked in Tübingen as well as John Hopkins trained. And then he went to Zurich, assistant professor and medical director for the stroke unit. And today we're talking with him in his function as a medical director of a world-renowned rehabilitation clinic called Cereneo. So welcome, Professor Luft, and thank you for your time.
Sure, my pleasure.
Let's jump right into the topic, Professor Luft. We don't want these videocasts to be too long. Can you maybe for, let's say, non-medical people explain shortly what a stroke actually is?
There are two types of stroke. One is in which too little blood arrives in the brain because one of the major vessels that supply the brain with blood is blocked. The blocking can come from a blood clot arising from the heart or from other vessels. There are a large number of causes of these blood clots and vessel occlusions, but in the end, one area of the brain does not receive enough blood, and then it loses its function, and then it dies eventually. And that leads to a symptom depending on which area is actually affected. So you know that in the brain, different parts of the brain are support or execute certain functions, such as the vision, hearing, movement, speech and language, etc. And depending on which part of the brain is affected, you will get a deficit. Usually it's a combined deficit. There are several deficits running in parallel. The most common is the hemiparesis, which means that you cannot move one side of the body. Mm-hmm. Now, the other type of stroke is not a lack of blood, but too much blood. It's a bleeding, so-called hemorrhage, into an area of the brain. Again, one area that has a certain function. And this, the cause of this is usually blood pressure, high blood pressure, a spike in blood pressure, but it may also have other causes. In the end, it also leads to, for example, this weakness of one side of the body, this hemiparesis. Mm-hmm. And in the acute phase, these two types of stroke are indistinguishable from their symptomatology. You need an image of the brain in a computed tomography scan or a magnetic resonance imaging scan to differentiate the hemorrhage from the lack of blood, and the lack of blood has a name. It's called ischemia. So there's ischemic and hemorrhagic stroke.
Okay, that was a good one. Thank you. If a patient or if someone gets a stroke, does the patient know or straight away, or can it be a mild one and you just feel silly, or is it always bum and you can't move anymore?
Yeah, so with all strokes, what is in common is the acute onset. So the onset is usually within seconds. Mm-hmm. Something that develops over longer periods of time is unlikely to be a stroke, with certain exceptions. Like usually there are exceptions, but the normal stroke is coming like a stroke, so within seconds. And then it really depends on the size and the area that is affected. Mm-hmm. So large strokes typically have, as I said, several symptoms that run in parallel, such as weakness plus language or speech difficulties plus dizziness plus vision loss, or only one selected function may be affected. Now, the problem is that only about 10 to 15% of brain areas, if they're affected, you will notice their deficiency immediately. Many of the other brain areas, those are called silent, at least silent for the neurologist, because it's difficult to pick up their malfunctioning in the neurologic exam. Most of these areas, when they're affected, you will not notice it, but maybe somebody else will notice it because you will have a slight change in behavior. You become more depressed or more aggressive, or you can't think so clearly. This can also be a stroke, but then it doesn't strike you so much. So it depends really on the area that is affected and the malfunctioning, the acute onset of the malfunctioning of that particular brain system that is affected by the ischemia or the hemorrhage.
Okay. So let's say, God forbid, hopefully not, but let's say I have a stroke. What's the next step for me and my family? What do I do?
So the only thing that you can do is call the emergency ambulance, emergency physician, paramedic, whoever brings you to the next large hospital in the shortest period of time. Because time really counts. Time is crucial. It's very similar to cardiac arrest. You know that cardiac arrest, you see all these defibrillators hanging around airports and train stations, etc. And there, every second counts. And of course, a cardiac arrest affects the entire body. Stroke doesn't affect the entire body, but only part of the brain. But this part of the brain dies as quickly as the entire body in a cardiac arrest situation. So the time really counts. And the thing that you can do to basically, in that stage, prevent the stroke from happening or from manifesting itself, to prevent the tissue from dying, is to reopen the vessel. Mm-hmm. And this reopening of the vessel is quite difficult. First of all, you need to know certain indications and contraindications. So meaning identifying the patients in which you can do what. But there are two types of procedures that can be done. One is you give a drug in the vein. That's the less effective but easier solution. Mm-hmm. The more complex solution is to go with a catheter and mechanically remove the clot. They're using like corkscrews or little baskets that they put around the clot and tear it out, or even suction devices that suction out the clot. And by nature, this is a relatively complex procedure that has a long learning curve. So you need specialists that do this frequently and have undergone long training.
Is that typically a neurosurgeon?
No, it's a neuroradiologist who does that. So it's not the neurologist, but it's typically the radiologist because it's done under X-ray.
Okay.
And because there are very few people that can do this, you will only find them in larger centers. And that's why it's usually advisable to go to a big center, a big stroke center directly.
Okay, good. Now coming more to the rehabilitation part, I've already had the chance to visit your clinic. It's amazing. What is, let's say, after a stroke and you want the very, very best neurorehabilitation, what are the elements? What is important for the patient? Why could, let's say, your clinic do better things than normal rehabilitation clinics? Is there, or if we want to be more general, what is important?
Well, I'm sort of in a unique position because I have an acute stroke service and I see the patients acutely and then I follow them in rehab. Mm-hmm. And the most important thing that I see with my patients, I experience with my patients on a daily basis, is that they must not give up hope. And they must not extrapolate the acute condition, which is usually very grim and doesn't look good and leads to decisions like discontinuation of care, giving up of hope. They should not extrapolate that into a later stage. 2 months after the stroke, things will look very different because the brain has the capacity of recovery. Mm-hmm. But that capacity depends on the patient, on you as a patient. you need to be motivated to recover, and you need to actually be very compliant with the therapy. And unfortunately, that therapy does not only involve swallowing a drug or a tablet every day, but it requires a lot of cooperation. Basically, patients need to become small athletes. And somebody who hasn't been an athlete before the stroke, of course, has a very hard time to become an athlete and work hard on their recovery. But as a rehabilitation expert and a rehabilitation center, we try to give the best environment to motivate patients to participate, make it pleasurable, make it comfortable, but on the other hand, make it very specific to advance their recovery. Now, a common approach of many rehabilitation programs is basically to recover you by compensating. That means that you learn to easy things, simple things in daily life. For example, by your good arm, if you can't move the weak arm anymore, and you sort of compensate in a way that will give you an immediate solution, but down the road, you will be unhappy because you still are not normal like before. Mm-hmm. So initially, we always focus on basically healing, recovering the patient to complete normality, knowing that this is not possible in many patients because our science of brain recovery hasn't advanced that far, at least currently. But we are still striving for it. Mm-hmm. We're still not giving up hope. Also, we as therapists and physicians. And this is very important because if you give up hope, there's a self-fulfilling prophecy that you will actually not achieve anything. So this is the initial focus. And but that requires...
Mm-hmm.
And that requires very specific interventions that consist of training, that consist of medical treatment, also with certain drugs in certain cases, and with neurophysiological interventions such as brain stimulation or muscular stimulation. There are a large set of different types of intervention that need to be not only selected carefully, but also personalized individually to the individual deficit profile. And that is something that is rather complex, requires, of course, a lot of knowledge, but also a lot of measurements, mm-hmm. Diagnostic measurements. I always compare it to treating blood pressure. You need to basically monitor blood pressure very tightly in order to select the best drugs and give them at the right time points to optimize. Mm-hmm. And while giving a blood pressure pill is a very one-dimensional thing, you just give it in a certain dose during the day. In rehab, we have many dimensions. We have the dimension of movement, we have the dimension of speech and language, the dimension of cognition with all their different functions. So it's a multidimensional approach that the personalization of which is much more complicated and multifaceted.
So do you have, if I can jump in here, do you have, let's say, special therapists only for speech and language?
Of course, yeah. These are different disciplines.
Can you give some feedback on this? Because I think this might be interesting. At least we get this question a lot, that people asking us for the language specialist, and then also in an international context, is the same therapist for an Arabic speaking person the same as for an English speaking person? So how does that work?
So first of all, every rehab institution has movement therapists. These may be even subdivided in physiotherapists and occupational therapists. They have speech and language therapists and neuropsychologists who treat higher brain functions such as attention, memory, executive function, etc. Mm-hmm. Now, you need specialties, experts for even different interventions within these different disciplines, within these different professions. You need, for example, experts in brain stimulation, experts in muscle stimulation, experts with certain training strategies. You need specialized nursing, because nursing is in rehabilitation does not mean just assisting the patient, but also needs to provoke independence and needs to provoke activity in daily life. So there are very specialized nurses involved. We actually have psychologists as part of the team. We have engineers as part of the team who are able to personalize the devices that we use. A number of devices are useful in rehabilitation, not only to assist the patient, but actually to train the patient. These can be, you can imagine very complex joysticks with which you can play computer games that help you in certain movements, for example, or other devices that help you focus better your attention on certain aspects of your visual field. Large technology knowledge that is required to optimize the use of these things.
Now that's maybe my last question, because when I went to visit your clinic, I saw like all these robotic things. I'm assuming these are very much and very advanced helpers, probably to get the movement back. Is that also something that you would say is part of a very, very unique and top high-end rehabilitation?
Yeah, certainly. We have a lot of devices. We use them a lot, but these are just tools for the therapist. The therapist needs to select these tools in a smart and clever way and address a certain individual deficit with a certain tool. And that expertise is something that is usually lacking. Even if you have a gym with a lot of devices, you put a patient in that gym, that does not solve the problem. You need to really know how to use and personalize these devices, because most of the devices are not easily applicable to you or to me after a stroke, but they need certain modifications. And for these, we actually need the engineers and developers that were originally involved in developing the devices, basically in the room. And that is the difficulty. And that is what we're trying to do at cereneo.
Super. Okay, Professor Luft, as I said, we don't want these podcasts to be too long. Many interesting insights, many things. At the bottom of this video, we will include this video into an article. You may also contact directly the Clinic Cereneo if there's any question, or you can contact us as Premium Switzerland, of course, and we will put the link or we will create the link to the clinic. Thank you so much. Much appreciated. And thanks a lot and have a wonderful day.
Thank you. Goodbye.
Thank you.